So instead of coming in with a bulldozer and tearing everything down and taking away all their medications and making them feel like we're doing something negative, I want you to sort of think of it as building them up. First, build that foundation of trust. Communicate with them. Show them that you're interested in their care and in their goals. Ask the patient and their caregiver what they've learned and what they understand about their illness and their medications. Inform the patient and caregiver about any evidence-based medicine that they may have not known about before. Listen to the patient's and the caregiver goals and expectations. And then develop a plan of care that includes the patient and the caregiver in the discussion. So part of our medication therapy management is going to has always, but more importantly now, includes medication coverage. Medicare is saying that we should provide all medications related to the terminal diagnosis and related coexisting conditions that contribute to the terminality of the patient. Importantly, Medicare wants us to be consistent with this decision-making process. So for the same type of patient, the same type of symptomology, the same disease categories, we're going to be saying similar things across the board about coverage. This doesn't mean that it's a checkbox process where everybody gets the same medication no matter what's going on. It still will be individual pharmaceutical care plans. Keeping that in mind, though, most drugs used for symptom management will be expected to be covered. Drugs not covered are going to require some sort of statement from the hospice physician stating why the medication is not related and therefore why it isn't covered. And how this is going to be done has not been spelled out by Medicare. Right now, individual hospice companies are coming up with their own sort of ways of dealing with this. Hopefully, it will be integrated into our system of home care, home base, and our relationship with OnePoint or whatever pharmacy you may use, so that there will be a process involved. And then remember, review medication list at every IDG. CMS has encouraged Part D sponsors to place beneficiary-specific prior authorizations for drugs used for symptom management. And this may or may not be already occurring in your area, where if a patient takes a prescription to a particular pharmacy and they're on hospice, they may be blocked from getting coverage from Medicare Part D because of the need for this prior authorization, especially for these classes of drugs: analgesics, antiemetics, laxatives, and anti-anxiety drugs. So this is what we should be doing now, what we should have been doing yesterday, and they may actually go back in time to review coverage for these particular symptomology, not just starting May 1st. So you may be at that sign where it says you're lost. Is it partially covered? Is it kind of related? Somebody has to pay. So I want to help you develop a simple way to organize this all in your mind. And doing that, we're coming up with what's called our bucket list. It helps us to put these medications that we've determined to either be related or not related, necessary or unnecessary, into their own buckets. So each one of those is a separate category. And if you take the medications and in your mind apply those buckets, put them in there, then I'll show you how at the end you can determine who's going to cover them. And coming soon, and I think it will be in conjunction with our 1-point pharmacy educators, they will help us roll out the new formulary, which is going to be the other part of determining who's going to pay for the medication. There's different ways to do a hospice formulary. Ours is going to have one that's symptom-based. There's about 28 symptoms, all of which we feel like pretty much will need to be covered by the hospice benefit. Then there's a disease system formulary that's separated into disease systems like cardiopulmonary, gastrointestinal, GI, and this formulary has a hierarchy scale of preference drugs based on cost. And then there's the prior authorization drugs, those drugs that are red flagged that we should avoid using at all costs if we can. So these red flag drugs are going to need prior authorization. There may be appropriate formulary substitutions for these drugs, and we'll use them when we can. And we got to remember to always use generic forms when available. And it's better if we all get used to writing the chemical or the generic name of the drug down too, and not rely so much as the brand names, because when they go out of copyright, they go back to their generic form anyways. Drugs not listed on the formulary will also need prior authorization if the patient is going to use them. So non-formulary drugs. And I can envision this, especially in the transition period, happening fairly frequently. A patient's requesting to continue a non-formulary drug, and there's a comparable formulary drug. So this should be offered and the patient family educated about similar effectiveness. And you should use your evidence-based medicine with this. Give them reasons that don't include just cost. In fact, the word cost should probably be kept out of it. However, there's going to be certain instances where hospices are going to be required to provide non-formulary drugs, especially when they're deemed necessary to meet the patient's needs and desired outcomes. This is a little cartoon. I think we're all affected by media and advertisement, and this little old lady's saying, that pill they advertise all the time on TV, I'm not sure it is, but I want it. And we see that similar attachments to medications and drugs, and that discontinuing or taking away or substituting can have a profound effect on these patients. So just to make it absolutely clear about clarifying payment responsibility, if a patient or a family member continues to request a drug that has been explained to them as not covered or has refused a formulary equivalent, the beneficiary may opt to still get the medication at the pharmacy, but the payment will no longer be available through Medicare Part D. The patient will have to pay for the drug themselves. This is a nice little algorithm that 1-Point Pharmacy developed for us. And you can see that the first 2 steps in it were the same steps as our little bucket system, determining what's related, what's not related, what's medically necessary or unnecessary. And then the third line is whether it's a preferred drug on our formulary. And then it flows from there as to whether it's covered by hospice, by the patient, or by Medicare Part D. So when these changes are made, it's important anytime you write an order or make a change in medications that there is follow-up. The nurse manager is going to be key in this. He or she is going to be assessing the effectiveness and possible side effects of medication changes. If new conditions arise, she's going to evaluate for the relatedness of the medication and revise the plan of care. The clinical manager She's going to be important. She's one step removed, but she can also be there to evaluate appropriate documentation. The physician, it's usually going to occur in IDG, but he needs to give them clear expectations of the time frame that this change should occur and what the follow-up should be. Pharmacist, you have to remember, is always one phone call away and a very good reference source. And importantly, we'll have to have our QAPI team bringing up the rear, reviewing diagnosis appropriateness, patient symptom relief surveys, and reviewing medication relatedness. So, as a summary, we started with those 4 buckets, and you take those 4 buckets and you determine who's going to be responsible. Is it hospice, patient, or Medicare Part D? Well, the hospice for sure is going to be responsible for any necessary and related medications. They're also possibly going to be responsible for necessary medications that are not on the formulary. The patient is going to be responsible for medications which are related but not necessary. They won't be able to use Medicare Part D. And it should be a rare circumstance when we need to use Medicare D. And when we do, there will need to be a written statement from the provider stating why it is not related and why hospice doesn't need to pay for it. And then there's the garbage bag category where things are both unrelated and unnecessary, and hopefully these are the drugs that we've already discontinued. So in summary, we've helped to define what's going to be the appropriate diagnoses for these patients, how to use medication management to help the patient have the right drug for the right reason, the only medications needed, and then determine if they will be covered as related to the terminal diagnosis. Learning the hospice formulary will help us educate, standardize evidence-based medical care, and will help us with cost containment. Thank you. So I'm Dr. Terry Hanlon. If you have any questions or concerns or ideas, you can email me at teresah@creeksidehospice.net. We also have the support of our regional clinical services led by Judith Amy, also Gretchen Schaefer and Gloria Mandel, who are well versed in rules and regulations, and you can contact them also.